This is a podcast by the Straits Times.
Hi, I'm Joyce Teo and you're listening to Heath Check. Today we're discussing a shift in how two Singapore hospitals are handling critically ill patients in their intensive care unit or ICU. When we think of ICUs, we picture highly clinical, stressful environments with patients hooked up to machines and flashing lights and alarms around them. The focus is solely on saving lives. But what happens when the machines aren't enough? And what if a patient needs more than technology to navigate a medical crisis? That's when an often misunderstood specialty comes in, and that is palliative care. Palliative care is about caring for people while they are living. It is appropriate at any stage of a serious illness, not just the terminal phase. By addressing physical pain, emotional distress, and spiritual needs, palliative care treats the whole person and supports their family when medicine alone isn't enough. So here in Singapore, Tan Tock Seng Hospital and National University Hospital, they recently launched a new initiative called A Kinder ICU that is supported by a 3.93 million grant from the Lien Foundation. Their aim is to integrate palliative care into standard ICU treatment. But what does this mean, right? Why is this significant and how is it going to happen? So these are questions that will be addressed by our two guests today. They are Assistant Professor Neo Han Ee. He's a senior consultant and head of the Palliative Medicine Department at Tan Tock Seng Hospital. He pursued a second specialization in palliative medicine after obtaining a specialist board certification in geriatric medicine. And we also have Ms Charmaine Sim. She's an advanced practice nurse at the Medical Intensive Care Unit at the National University Hospital. She's a highly skilled nurse who has received palliative care training. Hi, Dr. Neo. Hi, Charmaine. Welcome to Heath Check.
Hi, Joyce.
Hello, Joyce.
Good to have you both with us here. So we'll start with Dr. Neo. Dr. Neo, let's talk briefly about palliative care because I think the term scares some people. It's often misunderstood as something that's only delivered in the final days of life. So how do you explain ICU palliative care to the family of an ICU patient?
So maybe I'll just set the context a little. Perhaps 10 to 20 years ago, you have been right that palliative care is really delivered at the end of life, and people think of palliative care as a specialty that the doctor will come by, declare that time is short, make sure the patient is comfortable, and patient dies within short days. But that have changed in the recent 1 to 2 decades globally. The definition of palliative care has since changed to a service, that can be initiated once a diagnosis of an advanced life-limiting illness is made. So in such a situation, in the ICU, you have then a very interesting conflict of concepts. Because in intensive care, critical care, what you want to do is to give the person the best chance to survive. It is very technology-driven. You want the best outcome for the patient in terms of life prolongation. But palliative care brings in this notion of comfort, symptom relief, peaceful at the end of life.
It's misunderstood as having it in the last days of life, right? How do you actually broach the subject, right? Given that people think about it this way.
Yes, yeah. So I think nowadays in the ICU setting, it's very cleverly engineered into the conversation. So for example, if the ICU specialists know that this particular patient isn't going to do too well, right, based on science, based on medical facts and assessment, the ICU doctors will then bring the palliative care team in, usually into a family meeting or what we call a family conference. And they would then introduce us as part of the team, right, very naturally, and say that this is my team from palliative care. They are just part of my crew, and if things don't turn out too well or if your family members will suffer from any symptoms, they'll be here to make sure that all distressing symptoms are taken care of and they'll be comfortable. This treatment is not going to affect how your loved one is going to do, be it for good or for bad. Their role is to support me so that I take care of your family member well.
I see that sounds more reassuring, yeah. But with the Kinder ICU, you're bringing the care earlier, right? Like Charmaine, you talk to patients as well, right? Before the specialists actually come in, how do you do that? And we were talking about the misconception because you also mentioned that people will think that when you introduce palliative care, they assume that there's no hope for them.
Yeah, I think things is very different compared 2 years ago to now. Last time when we talk about palliative care, the family will think that, is he not going to make it? Is he going to die? And that's why you are speaking to me about this. But with the awareness that's built up in the public, nowadays when we talk to them, they understand where are we coming from. And we go in earlier to support them to find out how is the patient like as a person, what matters to the patient, and how is the family coping, and what are their concerns, and how can we address that for them to help them to have a smoother transition in this difficult period.
So actually, I agree with Charmaine because the members of the public now have also come to realize that at some point, palliative care is essential. In the ICU setting, many of our family members are very conflicted. On one hand, they want the best, for their loved ones. They want to give them the best opportunity to survive through a crisis. But yet, they could see how their loved one is suffering. They could also see whether their loved one is improving or deteriorating. They have to struggle between wanting to maintain hope while also preparing themselves for a possible untoward kind of outcome. So nowadays, family members actually want to discuss about palliative care when things are not looking well. We have seen patients with massive stroke, massive head injury that comes to the ICU team telling them that this is not how my father or mother would want to live out the rest of their lives. Can you get in some help? We want to remove the ventilator, for example. Yeah.
Oh, I see.
Yeah, so that they can pass away in dignity because they have told us before they wouldn't want to live this way.
Yep.
Right, so it's easier nowadays than in the
Yes,
past.
like this morning when I go into my patient room, the wife was telling me she thinks that the patient is suffering. So they could understand and they know that the treatment is not going to help. And they will start to ask, can I speak to a palliative care team and things like that. Yeah.
Oh, right.
The numbers
Okay.
are more compared to the past. Yeah. I think the awareness is created and people are more aware about it.
So the general awareness has gone up.
Yes.
I see. Okay. But in the ICU, there wasn't such an initiative, right? So if you're in the ICU, then what do you do, right? Given the lack of specialists that we have.
We used to know that the patient may need palliative, but we manage it ourselves. But we may not know how are we managing it the correct way because we wasn't trained that well before that. Yeah.
Okay. So what does it mean, right? What's the difference? And then as a patient, does it matter whether I speak to a generalist or a specialist palliative care?
So maybe I share in terms of nursing, what is the difference? When we integrate this palliative care into the Kinder ICU, we start to screen for patient actively, patient who require the palliative care needs. And we start to put them under our list and we start to talk to the family member and we refer them to medical social worker earlier.
Oh, meaning with the initiative, you actually screen them earlier, but before that,
It's more consultant-based. So the consultant will decide, this patient is not doing well, we shall refer to the palliative care team.
If I can just add on a bit, Charmaine. So the ICU setting is, you can imagine it's a very sterile and very almost like mechanistic environment because there's a lot of high-tech machines beeping away. The doctors and the nurses and the allied health professionals working in that environment is high-strung because we want to go in, use the top science and facts and evidence to try to save the patient's lives. That is the main focus. And when patients are perhaps not doing so well and family members are emotionally very laden and very touched, right? Because they are grieving, they couldn't quite make sense of why their loved one was walking around just 2 days ago and now fully dependent on life support. And it is very dependent on the leader of that team, the consultant of that team, whether the consultant has that natural humanistic kind of approach in the management of a patient. Would the consultant then, harness a team together and say that this is a grieving family member? You have to speak to this family member in a particular way, address certain concerns, because if you do not address these things, you can't move on to talk about the next step. So it's very dependent on the consultant, very dependent on personalities. Right? So that's why this Kinder ICU program that we have done, NUH and Tan Tock Seng in collaboration with Lien Foundation, creates a structured approach so that such a notion, such a concept is structurally embedded into the routine of an ICU environment.
right, so with the specialist, you can train the rest to have, do you call it the soft touch or to be more sensitive to the patients?
Yeah, so I think that there is both an art and science to it, right? Yeah, so if I go on too long, you let me know. It's a favorite topic. So amongst doctors and nurses, of course, in a way that we are trained, right, it is almost like we learned information, skill sets and knowledge in a very scientific kind of a manner. Procedural skills, pharmacological skills and things like that. But actually what we term as the soft touch, right, has its own science and art to it as well. So, for example, the way that we communicate with a grieving family member has its signs and behavioral patterns, right? And that comes with a different set of training. For example, the social workers will be trained in this in their universities and in their clinical profession to say that, and I digress a bit to set the context, right? So everyone has their own story. Our life is like a story laid out in front of us with its main characters, we being the protagonist, and there will be certain rules of the game. You do certain thing a certain manner. When you flip the pages, it's going to happen. But life is not a perfect story. Life will present with certain unexpected crises. And when this crisis suddenly disrupt how that narrative flow, that storyline gets disrupted, we are thrown into a mess, we can't make sense of it, and we behave in sometimes very horrible manner to ourselves, our family, and to the doctors that take care of our loved ones. The social workers are trained to see this disruption in that story, and they will help these family members make sense of that loss and try to bring back the human touch to it, to say, what would your father and mother have wanted if they knew and they could speak to us about what's happening now? They bring back this human aspect to that disrupted story, make sense of it, try to hold that emotion for their family member so that they can logically and rationally process through all these difficult emotions and then come up with a best decision for the loved one. So there are certain art and science and framework and behavioral kind of science to such a soft skill. And of course, this soft skill is not only amongst the social workers, but is also heavily emphasized in the palliative care training. Mm-hmm. Right? Yeah. So really, we are talking about a marriage of two disciplines: the critical care part, whereby sciences, procedural, precision, machines are important, and also a different aspect, which is the palliative care part, that talks about the symptom relief using medicine, but also the relief of emotional distress using behavioral sciences, grief counseling, and support.
Right, that's very interesting. I mean, especially in an ICU, and it goes against the work of a blood doctor trying to save life.
Yes, yes.
So for Charmaine, how was the training like, and how different was it compared with the usual nursing training?
Sure. The usual nursing training for ICU is always very fast-paced. And like what Dr. Neo mentioned is like machine and then data precise. I used to think that palliative care is something only towards the last few days until I really understand what palliative care is. Then I realized actually a lot of patients can have palliative care needs earlier. Then I see the difference when we focus on the emotion and psychosocial part. When we are in the ICU nurse, we are task-oriented. You want to meet a certain target of the blood pressure to make sure patient is fine. But on the other hand, there's patient family at the bedside. When we connect with them, we talk to them and find out how are they coping, and also find out how patient was before the admission. Because most of the time, the patient with us is already sedated. They come in because of head injury or other condition. So we will not know the patient very well unless we talk to the family member.
Right. But how does it change your work then? Do you carve out extra time for each patient before, after you do your usual stuff, or how does it work?
It does take up a little bit of time, but I think it makes a difference because the nurse will feel more satisfied because we get to know the patient better and we see how we help the family in terms to come into terms to accept that their loved one is really not doing well and what is best for their loved one. They see that we are also working very hard to use whatever technology, medicine we have to help their loved one. But meantime, we also don't want the patient to suffer too much when we are doing aggressive treatment. When you do aggressive treatment, you need to poke here, you need to poke there, you need to take blood. So we try to balance that. Sometimes we help the family member to come in terms like we will ask the family member, you have been coming for the past few days. How do you think the patient is doing?
Right. So it's actually spending a bit more time to kind of understand and get to know the family.
Or if I were to just add a little bit of context to it also, right? So, for example, the Chinese have a saying, I'll translate it, right? All human heart is made from flesh, So while you have an ICU team who is very gila, very good, all very tech and science heavy, right? When they encounter suffering in their workplace, they also feel miserable
morally
and sad,
distressed.
and morally distressed, especially when family members just can't move on, when things are futile, things are not looking well, and they had to do procedures that are painful for patients that they know will not benefit them. So they're imposing pain on the patient because the family cannot let go. So this bridging of palliative care into critical care then means that the ICU team now have the skill set, the soft touch, to be able to engage the patient's family members to help them understand why certain procedures may no longer be helpful and why certain things need to be done to keep the patient comfortable. And when the two has a connection emotionally, the grieving family and the ICU team, the sense of job satisfaction goes up much higher, and that is a good outcome to combat against what we would call moral distress and compassion fatigue.
I see. Interesting. That means, especially when this kind of cases, when they get complex and people are actually resistant, you might have to call in the specialist.
Yes.
Right. But Singapore, we have a shortage of such specialists, right? Tan Tock Seng itself has 14, am I right?
14, that's right.
Yeah, and then in the whole of Singapore, there are like 96 palliative care specialists. So how are we going to actually address this, right?
Yeah, so you're absolutely right. There's no way that we can have a limitless number of palliative care specialists, as much as I would like to grow my department to meet the whole population need, right? So the only way that we can make sure that quality care is delivered to the population is for all the specialists, right? The family medicine folks, the general medicine folks, the geriatrician, the surgeons, all to have very foundational palliative care skill sets so that they can handle most of the day-to-day kind of suffering, be it using pharmacological intervention medicine or the soft touch, as we have mentioned. But the more complex cases that requires a keener eye, a more trained kind of a lens, using second line or third line more complex painkillers, that's when they'll call the palliative care specialists in. So then in the ideal setting, everyone can do a bit of palliative care, and then we leave the more sophisticated, more complex, more high needs cases to the specialists to handle and focus their energy on. I would say that it is very much akin to, for example, everyone should know a bit of cardiology. For example, our GP friends, our family medicine will read an ECG and know this is a heart attack and give immediate treatment, So this is a fundamental knowledge of cardiology across all disciplines. But you still need the cardiologist to do, for example, a stent or, work with the surgeons for a bypass when it's something that's complicated. So that's what we are trying to move towards. Yeah, for all ICU doctors, nurses, and allied health staff to be equipped with basic palliative care and identify the subgroup of population that has got more complex needs for the specialist palliative care team to deep dive and to help care for them.
I see. Interesting. That means previously it was just left to the specialist to actually come in and do even all those basic conversations.
So I think this is the other good point that you brought up. The idea is not only to create structures to train everyone, but also it is to move the culture, of the ICU. In ICU setting whereby we may be very driven and very focused on procedures and on machines and on sciences and on numbers, the culture needs to shift towards one whereby we can integrate both the science as well as the hard side of medicine. So we see that happening in Tan Tock Seng over the past 12 years. 12 years ago, when we first entered ICU, we are greeted with a lens of suspicion, And, some welcome us, others, frown at us and wouldn't refer patients to us 12 years ago. But that has shifted because the ICU team could see how we add value to the daily routine and how the culture has shifted. We now can talk about patients, not only from a medical angle, but also from a family dynamics kind of an angle. And that adds that human flavor, like what Sister Charmaine has mentioned. What is the patient like beyond just the numbers and the machines, and how we can help them cope with the emotional burden that the family members are overbrimming with. And now they actively welcome us. So at the beginning, maybe we started off with just a handful of referrals 12 years ago. Now we are seeing about 220 cases a year based on 2025 statistics, right? And this number is projected to increase because we see each other's value. And now palliative care has become an important team player within the ICU kind of environment.
Right, it's a more holistic kind of care for everyone. Yeah. That's interesting. I mean, actually, I'm quite interested in this both, like the actually critical care part and then getting the healthcare staff to be in touch with their emotional side. Do you find that a challenge? Like, are some people resistant to it? Especially the doctors. I just want to save your life, right? And then for nurses as well, right?
Yeah, I think you are right. Everyone is different. So some of them have their own principle. They want to save the life. Yeah.
Which is more important.
Yes.
Than, okay, don't waste time on this. Let other people deal with it.
Yeah. So that's why when we integrate in, we also encounter some resistance. Like, why are you seeing so early? So we try to explain that we go in early, no matter which trajectory it goes, we are there to support. And that's why we introduce ourselves as support team as well, instead of palliative care for a better buy-in. Yeah.
So actually, when do you actually talk to them about it? Is there like a structure, or you wait to see whether they're ready?
We don't have an exact time frame. Usually not on the first day. Yeah. The second day, we'll see how is the patient doing. Then by the third day, we can see how is the family coping already. You know whether are they anxious. Then you can start to communicate with them. Then from there, you can address their concern and find out how much do they know and how much information do we need to break down for them to understand.
I'll give an example. I agree with Sister Charmaine. The first 2 days are probably not the most appropriate to broach a topic because family members just newly encounter this crisis and they cannot make sense of how things have suddenly changed from routine, normal to now crisis, whereby you might lose a very important person of your life irreversibly. The imminent existential threat just hit them. So, but the ICU doctors, through their experience, based on their diagnosis, their scans, they would know whether this case is likely not going to do well. And that's when they would refer to us. So we had one case some time ago. I de-identified the details for patient confidentiality. But this is a patient that is not a Singaporean citizen, right? So he came to Singapore to work for many, many years. Very well loved by the bosses. And he was about to fly back to his native land to have a reunion with the family, the wife and the children, before flying off to another country to start another piece of work. But before Chinese New Year, when he was preparing to go back, something happened. So he had massive brain injury because of a collapse, and he was left on a ventilator, unable to speak. So the family were expecting him back, and there he lies, unable to communicate. He haven't seen the family members for years, and the family, the wife and the children flew in, and they were at a loss of what to do. So obviously in such a situation, to paint a very obvious example, right? Then this is the case of ICU doctors clearly know things are not good. Family members is clearly grieving. They are not expecting their loved one to be in this state. The employer can't even verbalize and articulate what happened to the employee because it's so sudden. They also worry that on the way from overseas, an accident might happen because people were hasty and in a rush, right? So then the ICU team referred to the palliative care team early. And we come in, to explain to the family member what's happened to the brain and to the heart, what is the outcome that we are expecting, and move towards why we may eventually need to remove the ventilator because the patient is not recovering neurologically. There will be no recovery, and patient essentially will pass on with or without ventilator over time. But what the palliative care team does is that when we are in that room with the family, we hold that grief. We can, from a humanistic angle and by our training, almost second guess and predict what are the worries and fears and pain they're going through. For the wife, she's going to lose her husband. She's going to lose the breadwinner of the family, because two children that's still dependent financially. He's going to have difficulty explaining to the in-laws and the extended family what happened to my husband in a foreign land and going to die. There's all these things weighing in the background. For the daughter, I haven't seen my father for years, and then now he didn't even give me any instructions. He didn't tell me anything. I'm expecting to see my father back, and now he's gone. He's there, but he's gone. Who's going to take care of me? I'm going to move on to my next stage of education or career, and he won't be there to witness my marriage, and all these background losses are there. And of course, then the logistic part that we can predict, how we're going to take the body back, is there going to be workman compensation? So all these things actually we are able to predict. And the family members will not be in a state of mind to articulate all these things clearly to us because they are so emotionally overwhelmed. But without going through all these concerns and addressing them, step by step, they won't be able to move ahead. They would tell the doctors, and which they did, try, go on. But is it then fair for the patient? Because he may suffer from more procedural discomfort with no good outcome at the end of the day. Family members is going to put in a lot more financial resources, which they can already not afford, and then they may go bankrupt. The payment now is done by the employer under Singapore's laws, the healthcare employer kind of act. And the employer is going to go bankrupt with ICU costs at private rate. So I think this is a situation whereby the palliative care team coming in early can help clarify the situation, hold that grief, jointly discuss management plans with the doctors, the ICU doctors, nurses, as well as the family, and move ahead as to how best to take care of our patient in the right direction that's good for everyone.
Right. So actually in a situation without this kind of service, right, the patient will say try, and then you just left there to suffer.
So Singapore is unique. Singapore is unique in a sense that under Singapore's laws, when a patient loses mental capacity, right, especially when you're talking about life-sustaining treatment, the final decision lies with the doctor that's taking care of the patient. So in a situation whereby it's truly futile and nothing is going to benefit the patient and perhaps cause only more pain, the doctor is actually legally authorized, right, to make that call whether or not to continue that ventilatory support. But of course, if you were to withdraw and you don't hold that grief and emotion for the family member well, it can be a major disaster.
Yes.
The family members can remember that disaster, that crisis for years.
Yeah.
Every time there is an anniversary, every time there is a major event, social event, birthday and all that, they will remember what happened and they will be very emotionally charged.
Yeah.
So that is why I think palliative care coming in is important to be able to have good closure amidst a crisis.
Right. Otherwise might be more problems for the family as well, right? Mental health problems.
Yeah.
So before this Kinder ICU program, then we leave it to the individual ICU physicians team to decide how much emotions they want to deep dive into and how to address it. And we must remember that before this structured training and empowerment, we are all born differently. Some being more articulate, some being more emotive, some being more IQ heavy, some being less EQ heavy.
Yes, that's why I was just wondering. So it might be quite stressful actually for some of them.
That's right. So some things end up well, some things don't end up well. So with this whole program, we wanted everything to end up well.
Okay, so it kind of takes away some of the stress from the staff as well,
Correct.
right?
That's right.
Right. Charmaine, you mentioned that as well, right, for the nurses. Was there a particular case or family that you looked after recently that really touched you?
So recently, I have a patient. He came in because he had a very bad lung disease. So we noticed that he's not doing well because the support is going higher and higher. So then I had a conversation with him to find out what matters most to him and what he values and what he wants. He said, "Thanks for having this conversation with me. I actually waiting for someone to ask me, but nobody did that." I reflected that, just a conversation, finding out what the patient really wants, make a difference. Because a week later, he deteriorated. And he did share with me he didn't want the breathing tube to be put in. Our conversation also made him realize that he need to hold an important conversation with his family member. So he also managed to speak to his children and his wife, what to do if anything happened. So there is closure for the family to know what he's prepared for and what he actually wanted. Yeah. Because if they don't know what he really wants, as children, as wife, they will want to do the best. They will want to put in the breathing tube if possible to prolong as long as possible.
Right.
But if we find out that what is most important to him and what he values, then we can honor his wish to help him to have more dignified care.
Right.
Yeah.
It's actually fantastic. Actually, you can change mindset and make it easier for people to talk about dying.
Yes.
Which used to be so difficult.
Yeah. Especially when dying remains a taboo in a very Asian kind of a society. It's got better. 10 years ago, no family member, no old folk will talk to their children about death and dying. But we see this discussion being much more prevalent. But still, death and dying remains a taboo, until some event triggers it. Often it's maybe a major crisis or sickness or death in another family member, and the father or mother then just take the opportunity to tell the children, if ever I end up like that, then please, So it's very opportunistic. And all the more it's important then for us to try to bring out the patient's thinking, patient's values, and patient's expressed preferences before. Right? Sometimes we may know the patient from a previous admission and we would know how he or she struggled in the ICU and whether he or she have expressed any wishes in a previous ICU admission. Sometimes we have to dig it out by prompting the family member and say, based on what you knew of your father and mother, what would he would have wanted if he knew this is the situation? Has he given you any instructions? What would he want? Yeah, so this is important because for children, especially in the Asian society, we are brought up knowing that filial piety is a virtue. And it is a virtue. It is a virtue, right? But sometimes filial piety also creates a lot of sense of guilt because we do not know whether our decision for our loved one is the right one or not. Right? So when doctors come by and ask family members, medically we feel it's time to let go and let nature take its course. Family members may feel very burdened that if I were to agree to this, then I'm basically telling the doctor that that's it, you don't need to try anymore to prolong life and no more hope will be there. And they have to bear that guilt for the rest of their life. So I think it is then important to bring in again this soft skill set whereby we try to find out who he was as a person, what were his values and wishes, and try to guess if he didn't tell us what he would have wanted. That would take that guilt component away from family members because they know that this is what my father or mother would have wanted. That decision then weighs less heavily on the family members.
And we usually say it's what we recommend instead of them making the decision.
That's right.
Yes. So that takes the responsibility away from them.
To help them with the guilt.
The guilt. But it's also a
joint decision.
Yeah.
Right. To have that support,
Yes.
right, for the person. Our healthcare actually is a more holistic kind of care,
Yes.
right? So we need more specialists. Or more generalists and specialists, basically,
Yeah.
right?
Yeah.
So how many nurses have been trained already? The initiative started last year, right?
We are planning to train more nurses, but currently we train them on the assessment tool and the way they communicate, and we also build up a community of practice. In NUH itself, we train about 70s. We are working slowly to increase the number because we see the needs of a generalist palliative nurse as well. Because they are at the bedside most of the time, and they see family member in and out, or whether did they go home or not, or are they stressed at the bedside, or do they still have to run in and out to take care of the children at home or the elderly at home, but still need to visit at the same time. So being able to communicate with them every day, that builds trust and relationship. So when they have any difficulties or they find there's some question they want to ask, they will be quite open to approach us and that helps. We don't want them to keep everything to themselves. Then it may accumulate, and then at the end of the day, they may not be able to hold that emotion. Yeah.
Right. Okay. So as more nurses are trained and more people will be able to have that kind of conversation.
Yes. Yeah.
So we're going to wrap up the podcast. We're going to ask Dr. Neo about this target, right? Because previously when we spoke about the initiative, you said that in Tan Tock Seng Hospital, with that team of specialists that you have, right, you were saying that roughly 1 in 4 patients could get some form of palliative support.
So at the current state, for all patients who eventually pass away in the ICU, right, 1 in 4 will have access to palliative care. This is before the Lien Foundation A Kinder ICU program kicks in, right? So 1 in 4 is actually a pretty good figure, even in a global scene. I would say that with this program that kicks off between NUH and Tan Tock Seng, when it succeeds and it builds such a program, we are truly at the leading edge of the ICU palliative care piece globally. People would be very envious to know that the palliative care team and the ICU team work so much hand in hand, learning from each other. So I think before this program, we have 1 in 4 patients who pass away to have access to specialist palliative care. At the end of this program, over the next 3 to 4 years, we expect all patients, the minute that they go into the ICU, the process will kickstart, all will receive some form of palliative care. For those that are doing well, they will have sort of a palliative care assessment, remembering that palliative care does not mean end of life, right? We're trying to also relieve symptoms for curative cases. So they will all be assessed for their palliative care needs, be it symptom or emotion or family, so that everyone will have access to palliative care at the end of the day.
That is assuming in 3 to 4 years' time, every staff in the ICU, they're trained in this.
Yes, so with this collaboration, we also build out some micro-learning program for the ground nurses to learn the basic palliative care. So for that, we aim to train almost more than 500 nurses and doctors on the ground so that at least they can provide the basic palliative care.
Okay, that sounds good. That's fantastic. I just have one last question because Charmaine, you mentioned that when you spoke to the patient, he wanted to talk about it, but he didn't broach the subject, right? So it helped when you actually talked to him about it. But then there are all those patients, the other side, maybe those patients who never actually want to talk about it, but it was time to talk about it. Like Dr. Neo, how would you actually handle these cases?
This is very difficult, and thank you for giving me this opportunity for advocacy. I'll give you a short story. So there are patients whereby they're on the ventilator with a tube in their mouth, right? They need the ventilator because their lungs are not strong enough to breathe on their own. They are mentally alert because they do not need the medication to keep them calm, and they're relatively comfortable. But this group of patients are really torn because they are being posed that question. If you want to live on, we need to put a tube in your throat and you have to live on the machine for the rest of your life. Without this machine, potentially you would die within short hours. Only a minority may get better over time, but it's fraught with a lot of crises along the way. Would you want us to go ahead with the surgery to insert the tube in your throat and hook you on a machine for the rest of your life? Or would you prefer that we take it off and let nature take its course? It's a very difficult conversation because you haven't thought about this question about what is the minimum quality of life you want to live by. Right? What is meaningful quality of life to you? When posed with such a difficult question, most people would be at a loss. The majority would say, you just try lah, because I'm not prepared for death. There's no better alternative. But the alternative of living with a machine, while extending life, also comes with its own burden to the patient and to the family. So I think this is an opportunity and I thought an alarm bell to ring for all the audiences listening to this podcast to actively think about your own death. You cannot assume that you pass away in your sleep like everyone wants to. That perhaps is a minority. You have to think about when it's your time and things don't go as well as you thought it would be, and your quality of life will be impacted. And there is great machines out there that can sustain life, Would you want to proceed, or would you want to give clear instructions to your children about what to do and what not to do?
Right, it's food for thought. So from what you say, even though it's sad, but it's a real fact of life, right?
It's a fact of life.
Most people don't just die like quietly and peacefully.
Yeah, just to qualify that, right? So by that we mean, I'll give you an example. My great-grandmother at the age of 92, the government wants to shift her from kampong to HDB. Obviously very resistant. So she said she will go back to her room to sleep. She slept and her wish of not going to the HDB fulfilled. But before that, she was still, mild dementia, but speaking, But this kind of thing happens to less than 1% of the population, including your road traffic accidents and your flower pot that hit your head from the HDB. This is a minority. I mean, there will be still a large number of people with all sorts of different diseases, cancers and organ failure that will, with a bit of help from doctors, pass away in their sleep, be it from a bit of help from medications or a natural process of organ failure, they will fall asleep. Right? But often with a bit of help. Then there will be that group whereby they may then need to confront that difficult questions. Would I want life support? And at what cost? Not financial cost, but quality of life cost. Yeah, that is the question that we have to answer. Yeah.
Right. So even though you say more people are aware, but it's a question that I think a lot of people don't quite think about yet, right?
Yeah, sometimes like you say, what if they are not ready? Sometimes we see they keep coming in and out of the ICU for the same problem. When we want to talk to them, they are not ready. But I think it's good that we bring up the topic because it set them thinking.
Right.
Set them thinking. They may not have an answer for me. It doesn't matter. But I trigger something that they can think about and discuss with the family member and talk about it.
Right.
Yeah.
It gives the family actually time to actually process the reality as well, right?
Yeah. Of course, between me and Charmaine, when we discuss this within the team also, the important highlight point is that while we try to integrate palliative into the ICU, we're not trying to sell the notion that we should give up. When things are reversible, when patients have a reasonable chance, we should try with modern technology, with the best evidences, best medicines. But when things don't do well, palliative care is there as a safety net to make sure that distressing symptoms are relieved, emotional burden is shouldered with a team, and we try to aim for good closure, both for the patient and from the family. That's what we are trying to say here.
That's true. I mean, is this care given when the person is living actually? Do you say good death?
Yes.
To
good death.
Yes, to have a good death. So
important is also the closure of the family because they continue to live on with it.
That's true.
Yeah.
Otherwise, the grief.
Yes.
Can't imagine. Yeah. Thank you very much today for your insights, Dr. Neo and Charmaine. That was wonderful. I hope it gets people thinking about, just talking about dying actually.
Yeah.
Thank you for having us here.
Yeah. Thanks very much.
Well, that's a wrap for Health Check, a podcast series by the Straits Times. Don't forget to follow Health Check for free on your favorite audio apps, Apple Podcasts and Spotify. Like us and give us a rating. This episode is edited by Amirul Karim. Thanks for listening.
Send your feedback to podcast@sph.com.sg. Find us on Apple Podcasts, Spotify, or within our Straits Times app. Thanks for listening.